Hi, everyone. Thanks for joining us for this latest installment of Clinician's Brief, the podcast, where we get to have the conversations behind our content. I'm your host, Dr. Alyssa Watson, and today I am so excited to welcome back a repeat guest on the podcast, Dr. Jason Tarricone. Dr. Tarricone is a veterinary surgeon from Palm Beach Veterinary Specialists, which is in West Palm Beach, Florida. This is his second appearance on the podcast. Earlier this year, we had the extreme pleasure of talking about his top 5 spay and neuter complications. It was a wonderful episode. I found it really informative. And today we are going to be talking about another abdominal procedure. This is probably, next to a spay, this is probably the second most common abdominal procedure that I perform in general practice. So again, another really wonderful practical topic. And we are going to be talking about his top 5 indications for cystotomy in both the dog and the cat. So welcome back to the show. It's great to see you again. For anyone that wasn't able to catch your earlier episode, if you wouldn't mind just giving us a brief, quick rundown summary of your background, that would be great.
Yeah, so I'm originally from Long Island, New York. I happened to work as a technician for a few years after going to college, and then ultimately went to vet school at the University of Illinois. After I did my rotating internship at Cornell University, and then ended up doing a surgical residency at Red Bank Veterinary Hospital in Tinton Falls, New Jersey. And ever since my residency, I've been down here in West Palm Beach at VCA Palm Beach Veterinary Specialists.
Yeah. And I think I remember from our previous episode that you said you were one that kind of came into this idea of being a veterinarian a little later in life. You weren't one that, wanted to do it since the time you were little.
Oh yeah, no, I decided I was going to be a vet. I guess junior year is what we call junior year of college. Like I was writing this stupid paper for I think it was not political, a philosophy paper, and I was like, this is horrible. Like, what am I doing? And then I was like, I didn't even finish the paper, and I emailed the dean. I was like, I'm switching my majors. This is what I'm going to do, and kind of been on track for that ever since.
That's really funny. When I was in college, I did always know I wanted to be a veterinarian. From the time I was 5, I was one of those people. So I actually majored in chemistry in undergrad and was getting all my prereqs. But I took Latin because I thought that would be a good base for, medical terminology and things like that. And I really enjoyed it. I ended up getting a double major in chemistry and ancient studies. And I wrote my thesis on, I think Roman games and the use of animals in the Colosseum and stuff. So.
Oh wow, that's crazy. It's always so surprising, the crazy backgrounds that everybody has. Who would think that?
Yeah, exactly. Who would think that you would end up? It was. I've actually met one other veterinarian though that also had a major in ancient studies. So shout out to ancient studies majors everywhere. They're awesome.
Yeah. An unknown track to vet school.
Right. All right. Well, we'll stop this trip down memory lane and we will get into what everybody's actually here to learn about, which is cystotomy and the dog and the cat. Obviously, I said in the introduction, this is a pretty common procedure for general practitioners like myself. But, I do find that oftentimes I'm performing these for, uroliths, for stones, and which, not surprising, that's going to be your number one indication here. So we'll start off talking about that. And then later in the episode, we'll get into some of these more, maybe less common reasons to go ahead and do a cystotomy. I had a question. You did mention in the article that with dogs and cats, the incidence of uroliths is pretty similar at right about 20% for each species. I will tell you that I have kind of seen a shift recently with cats towards prioritizing medical management, trying to dissolve stones before resorting to surgery. And so it made me wonder, if the incidence is the same, is the stone makeup usually the same between dogs and cats, or can that be different?
So overall, both dogs and cats, they get struvites and calcium oxalates. I think the big difference that at least, kind of seeing in cats is that cats can get a sterile struvite stone formation, which we don't really see in dogs, because usually when we're seeing a dog, it's a struvite stone is almost always associated with a urinary tract infection. That's definitely not the case in cats. Kind of because the struvite stones are more likely to be medically dissolved, if you're seeing a cat that just happens to have a stone, it's worthwhile to at least try the medical dissolution, assuming you don't have any other risk factors or anything like that, that it's going to be a calcium oxalate stone, because there's some chance, God only knows what the actual percentage is, that you may be able to be successful and kind of avoid surgery in that animal.
And I know that, your expertise is surgery, but I'm going to hit you with a bunch of medical
Oh yeah.
management questions here. I'm so sorry. Um, first question, and you kind of touched on this a little bit. So if cats get this sterile cystitis, whenever you're trying, if you're trying to do medical dissolution first, is it really important to always use an antibiotic with that dietary, change, or can you skip that in cats?
That's a good question. I was kind of pumping our internist for a little bit of information, because I was like, wow, there's a lot of questions about, medical management, but it probably is like the safest thing to do, because, any animal can get a urinary tract infection. I guess there is the argument for, um, you know, using like appropriate and judicial use of antibiotics. And so, that may be something that may change. Like there's no ironclad recommendations one way or another, but overall, like if you're attempting medical dissolution, the gold standard is, doing antibiotics for until the stones are resolved, and, also doing some sort of like repeated imaging. But it is a good thought. Like I wonder, if in cats, like if it may be beneficial to maybe hold off on doing antibiotics, especially if they don't have any other clear signs that they may have a urinary tract infection.
Okay. And then you mentioned repeat imaging. So how long do you wait before you get that animal back in, you take an x-ray, and you, as a surgeon, say, woohoo, we get to go to surgery now?
Yeah. Yeah, I mean, I would probably ballpark like maybe repeating the X-rays in about a month. Like the conventional knowledge is that stones should be reabsorbed between like 1 and 2 months after you start medical dissolution. Um, you know, Obviously it does come down to a cost benefit analysis for the owners. Like there may be some people that advocate for taking X-rays every 2 weeks, but I think if you set the ballpark of doing it about a month later, I think that you'll give it enough time to see that the stones are dissolving, and see at least you're along the right track. And if you do it, say any shorter period of time than that, you may be like, oh, I think the stones might be smaller, but I can't really tell. So I think that's a good ballpark answer.
Okay, that's excellent. Thank you. Let's go ahead and move on. I want to talk about some of these less common reasons to do a cystotomy, at least for me. And the second one on your list is biopsy, or even like resection of a bladder mass. And, this again is something that we have a lot more tools now than we had, when I first started practicing. So we've got a lot better ways to kind of help us identify, or at least, try to differentiate, prioritize a benign mass from, a malignant bladder mass. What clues does like the location of the mass within the bladder provide? When you're initially staging these, what are you looking at?
Yeah, so location is really what it comes down to. So, if we see more of an apical bladder mass, it does make us more inclined that it's more likely to be a benign process. So dogs can have either like a urachal diverticulum, which is something that will show up on some ultrasounds, and it kind of can look like it may be a mass. Like that's probably, but that almost always is at the apex. Technically speaking, TCC can end up anywhere in the bladder, but if we do see it closer down to the trigone, it does make us at least more suspicious that it may be TCC over something else.
Okay. And then, when it's not in that typical trigon location, there's these tests now, like the BRAF testing and things like that. Do you always perform those before you go in and get a biopsy, or do you think that a biopsy is more likely to yield a definitive diagnosis if that mass is further away from the trigon?
So, I mean, I think a biopsy is going to be the gold standard way of giving you an answer, because even though technically speaking, with a biopsy, you can have open to interpretation of false negatives, but it is possible for a BRAF test to be inaccurate as well. I usually advocate for biopsy if it seems like it's in a biopsyable location. But again, it comes down to what an owner's perspective is, what the size of the mass is. Like, so it does come down to just a conversation. But I usually end up recommending a biopsy of these masses.
Okay. Biopsyable. I like that word.
Yeah.
um, So
make up a lot of words.
I love them. I love made up medical terms. They're my favorite. It's
Yeah.
better than trying to figure out like somebody else's acronyms in their record.
Oh yeah.
So,
Yeah, there's definitely words that like in our autocorrect that always pop up with like, is this a word? And I'm like, it is to me.
it is to me. It is to me. So I have another kind of question. This is one that, again, over the years, I have seen, a lot of different opinions on this. And this was, I was taught that if you suspected a dog had a bladder mass, like you should never, ever cystocentesis that bladder. You should never stick a needle in that because, you would risk seeding the abdomen. I'm not sure, how real that risk is, if it's more theoretical, and does that apply, when we're looking to do something like a cystotomy or a biopsy?
So like, this is definitely like, I agree with you in terms of like when you come out of vet school, you're taught like if there's any sort of like if there's any mass that may be in the bladder, like absolutely do not stick a needle into it because you're definitely going to see the admin and that animal is going to die a horrible death as a result of it. On the flip side, like we take these animals to surgery, relatively frequently, and it's not like that we're completely walling off the bladder itself, like from the rest of the abdomen. Obviously, we'll exteriorize it, but the urine does get into the belly, and I'm yet to see a case that will have tumor that's going to regrow throughout the abdomen. So I do think it is a theoretical risk, but then you talk to some other people who have had completely different experiences. One of my mentors in residency loved to tell this story about when he was in vet school. One of the professors had like done a cystotomy on a dog and like had happened to notice a little mass and thought nothing of it. Years later, the dog ended up developing like having just this mysterious abdominal mass, and he allegedly could like see his handprint from where he had done it because it was all TCC that has spread. But I know of people, I know of times where we will where we will aspirate masses like that may be in the
Mhm.
bladder, and I'm yet to see a case where we've actually seen seeding into the abdomen. So I think it's a reasonable thing to be cautious about. And if
Mhm.
there's a less invasive way to do it, it probably makes sense. But I do really think that for the most part, it probably is more theoretical than anything.
And then if you do get in there, and you find that you have a mass that you think is just resectable to go ahead and biopsy, how much of the bladder are you able to remove?
You can remove a large amount of the bladder as long as you leave the trigone intact. You can remove essentially as long as you can make a bag that has the trigone intact. You can remove up pretty much most of that bladder. There have been some there. Usually the masses end up as tissue expanders, so it might look like the blood like that. The entire wall of the bladder in a particular area is all mass, but a lot of times it helps to grow. I have had it. There is one case in particular that I was the most scared that I have been in terms of doing a resectable mass, and I would ballpark that probably removed about 70% of that dog's bladder. But it really comes down to just being aware of the anatomy. So for most of it, it's fine. But as you get close to the trigone, just really making sure that you know where your ureteral openings are, making sure like you have to remember that the ureter doesn't come straight into the bladder. It does tunnel through the wall a little bit. So like in that case, like as I really started to, recognize I might be a little bit in over my head, like putting catheters like into the ureteral opening so I could really feel where the ureter was running to make sure that A, we didn't cut through it, and B, that as we're closing it, that we didn't suture it off. If there are things that you can do to re-implant a ureter, but obviously it's something that you don't want to end up doing if you don't have to. But you can remove more bladder than you think. Granted, should you is a whole nother question.
All right, excellent. And we're going to talk a little bit more about ureters a little later. So after the
Yeah.
break, I think.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serolaner Moxidectin and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serolaner belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
Okay, let's talk about emergencies. So there is definitely an emergency indication for cystotomy that was on your list. That is a urinary bladder rupture. What are the most common causes of bladder rupture that we see, in our patients?
So blunt force trauma, whether it being hit by a car, falling, kicked in the stomach by a deer, seen a dog that was kicked by the horse that had ruptured its bladder, like blunt force trauma. Whenever you see an animal with blunt force trauma, you definitely need to think about, at least assessing the animal's bladder, making sure that it doesn't, just on an AFAST or a POCUS, whatever your terminology of choice is, just making sure that the bladder's intact, that you don't see free fluid.
Okay. All right. Also, some secondary to urethral obstruction, I think, is probably the other time that I've seen a bladder rupture in a cat. Yeah. Yeah.
Mm-hmm.
So,
yeah.
So this is when you are going in, and I've never had to do this, thank goodness. But I've often wondered, there is a tear or a rent in the bladder. So if I'm going in to repair this, can I just sew up that rent or tear, or should I be making like another cystotomy and evaluating the bladder through a different incision?
I think it matters almost more on the location of the tear than anything, because sometimes it can be really difficult to even figure out where the tear is. Sometimes it's obvious. And so if you have, if it's on the ventral surface of the bladder, you're usually going to be able to visualize it. And typically what you can do to help you figure out where it's coming from is you can always pass a urinary catheter, and you can do retrograde passage of saline, and you should be able to at least figure out where it is leaking from. If it's on the ventral aspect of the bladder, kind of in a location similar to where you're going to do a cystotomy, you don't have to make a whole another incision. Most likely, I would probably just freshen those edges, because there's going to be some degree of chronicity, so you're back to normal healthy bleeding tissue, and that way you can usually just close it as a normal cystotomy would be closed. It's always a good idea to pressure check afterwards. So usually, depending on the circumstance, like placing a catheter, making sure that it's holding pressure. Kind of one of the other questions is if I've seen some animals that have had a distal or a proximal urethral tear that even after you close all of the defects in the bladder, that you still see that urine is leaking from somewhere, but you can't really figure out where. So it's always a good idea to put a urinary catheter in these dogs afterwards. That being said, if you're dealing with a defect on the dorsal aspect of the bladder, just thinking about the logistics of surgery, you may have to, it might be more difficult to flip the bladder over so that you can get to suturing it. So in that circumstance, it probably is more beneficial to make a ventral cystotomy, so you can open up and evaluate really the lumen of the bladder, and even kind of close it from the inside out.
That's really interesting. I wouldn't have even thought to close it from the inside out. And then when you are closing, that's another thing that I think there's a lot of people have questions about, or at least a lot of different surgical approaches to closure. Are we doing an inverting pattern? Are we doing just a simple closure? What are you doing these days?
So I usually will do a simple interrupted. I know of plenty of people that will do simple, and I'll do a single layer simple interrupted. I know people, especially if there's a really thickened bladder, will do simple continuous and do 2 layers of there's no right answer. There's no real wrong answer. 100% of the times where I've had to revise a cystotomy from somebody else, it has been a simple continuous closure that has failed in one way or another. I learned in my residency, because I always thought that doing an inverting pattern, it looks so nice, it's actually more likely to be watertight. That is not true. An appositional pattern, like an interrupted or a simple continuous, is actually the most likely to be watertight. But I typically just do a simple interrupted pattern, because all of the ones that I've seen have failed have been simple continuouses.
Excellent, thank you. Let's move on to ectopic ureters. We kind of talked about this, or we touched on it really briefly earlier. This, again, is not a surgery that is in my wheelhouse. I would not I don't think I would ever consider doing this myself, but I would love to discuss, how do I recognize this condition, so that I can refer it over to somebody like yourself who can appropriately handle it. It's a congenital condition, so I assume most patients are diagnosed at a young age, but can you talk a little bit about any breed or sex predilections? How do we find these?
Yeah, so it's definitely more predisposed to happen in females compared to males. And history is really the most important thing. So it is a congenital condition. It is an anatomic abnormality that they overall have since birth. Excuse me. Um, so it is really, really important to get a really good, thorough history. And when it comes to history, the owners may say that they're urinating inappropriately. Is it that they're consciously inappropriately urinating? Are they urinating all the time? Like, you should be able to ask this owner, like, is this dog's back end wet all of the time, 24/7, whenever you touch it? And if the answer to that question is yes, like, that really gets me the most concern for an ectopic ureter, because they still should have normal urinations, but they also, should just have like a constant dribble in one way, shape, or form. Sometimes it gets confused with some degree of urethral incompetence. So there are some dogs that, whenever they bark, they happen to dribble urine, but that's the only time that they do it. That is, to me, is a different, doesn't necessarily worry me as much about being an ectopic ureter. Also, dogs that have had a normal life that then develop having urinary incontinence, either after their spay or just when they happen to even be a little bit older, makes me a lot less suspicious that it's an ectopic ureter.
Okay. And then how do you definitively diagnose these? What do you use? Imaging? What do you?
Yeah, so there's a couple different ways to diagnose it. It depends on, what you have available in your hospital. Typically, what we'll do here is we'll do a CT scan of the abdomen, and usually with contrast, and hope that we can kind of see the ureteral jet of the contrast in an inappropriate location. Sometimes I've also done cystoscopy, especially on female dogs, just because it's easier to access, to actually visualize where the ureter in itself is inserting inappropriately. Sometimes in surgery, you can also do contrast assisted fluoroscopy, where you can actually inject into the kidney and you can trace the ureter all the way down, so you can see, first where it is inserting appropriately, and then after you do your repair, to kind of confirm, for lack of a better term, that it's fixed. And I'm sure that there are radiologists out there that are really good at ultrasounds, that are doing a really good evaluation as well, who can probably see the ectopic ureter.
And my understanding is there's kind of two types of the ectopic ureter. There's the intramural and the extramural. So how do they differ, and do they have different, respective options for surgically repairing them?
Yeah, so a intramural ectopic ureter is where the ureter travels towards the bladder. The ureter melds with the bladder wall at some point in a somewhat normal location. However, the ureter itself will tunnel along the wall past the urethral sphincter, and insert somewhere into the urethra. Sometimes you can have a intramural ectopic ureter can have a normal opening and continue to tunnel as well. Whereas an extramural ectopic ureter, the tube of the ureter just travels in a completely abnormal location, and the first time where it meets the urinary tract is past the urethral sphincter. For a extramural ectopic ureter, you do have to re-implant it into the bladder. Technically, you can do it anywhere, but you try to put it into a more anatomical location like the trigone. For an intramural ectopic ureter, there are a couple of different options. So those have the ability to be repaired, quote unquote, minimally invasively with laser assisted cystoscopy, where basically you find the ureteral opening in the urethra, and you stick a guide wire in, and you just kind of cut cut the wall in between the ureter and the lumen, and you can take it all the way back basically through the urethral sphincter. The other option is you can also repair those surgically, where you do a cystotomy, and you either catheterize or identify in one way, shape, or another where it's tunneling inappropriately in the wall, and then you just place a couple of sutures across it to kind of tighten it down.
Yeah. Sounds really, really fun and interesting.
It is. I mean, they really are fun surgeries because it's, like there is a little bit of detective work, and you get to they're just fun.
They're just fun. All right, we're going to talk about your last indication for cystotomy now, and that is collection of samples for biopsy and culture when you have a patient with refractory cystitis. And so does this biopsy technique really differ, from the technique you use when you're biopsying a mass?
It does. Usually, like if I'm going to be biopsying a mass, like I'm going to attempt to do an excisional biopsy. So especially like if it's a mass that's in the apex, typically I'll usually like pass a suture through the mass and kind of hold it up, and then just kind of cut across it. When we're talking about a biopsy that we're looking for biopsy and culture just of a generalized like bladder pathology, and usually just making your incision for the cystotomy and then just another incision right next to it just to excise a little bit of the wall is typically what I would do. And you can make sure that you get a big enough sample so that you have so you have enough for everything. And then the closure is essentially identical to what it would be like for a normal cystotomy. And that way you're not really like altering the folds and everything of the bladder.
Okay. And then when you're collecting these samples for culture, what benefits do you get from getting, a sample via cystotomy versus just getting a urine sample with a cystocentesis?
So the big advantage is that you're getting a full thickness biopsy. So sometimes we can see, chronic urinary tract infections, or I guess, chronic cystitis and bladder infections where the bacteria is really in the mucosa. And you're not going to, you may not get that, either the same bacteria or the right culture results if you don't get the wall of the bladder.
Okay. And then how should we be preparing those? Like, how should those samples be processed?
Yeah, so when you're in a perfect world, what you would do is, especially for your sterile culture, you would use like a sterile white top tube because you want to minimize the chance for contamination. So the easiest way is if you have a sterile non-additive tube, you can have that on your surgery table. You get your sample, and then you just put it right into the sterile tube, and then you can hand it off to to whoever your non-sterile assistant is, so it doesn't get lost. That way, you're handling it as little as possible, and there's the least potential for contamination. In terms of the sample that you're sending out for biopsy, typically just putting into a formalin container. Like it may be worthwhile to put it into a cassette depending on the size that you have, just so it doesn't get lost in the jar. But that's typically what we try to do here.
Yeah. Sometimes I've with smaller samples like that too, I've kind of stuck them to a tongue depressor or something and floated that in a jar, and that sometimes helps as well.
Yeah, or sometimes you can take the cardboard off of the on your suture packet. There's like that cardboard or whatever paper, and you can put the samples on that and just plop it in there.
Yeah, good tips.
Yeah.
So I will wanted to talk. I mean, you talked a little bit about you're generally closing these, the same way you would a cystotomy. However, do you find if we have, a really inflamed bladder or really chronic problems that the tissue is more difficult to handle or more fragile? I remember this case I had where the dog had cystotomy, and we needed to do a cystotomy. The dog couldn't urinate. I couldn't pass a urinary catheter. And so we went in order to, retrograde the catheter, and the bladder was just so fragile. It just like tore. And so any tips on, how to handle those bladders when they're very, very fragile, or they're very inflamed or chronic?
Yeah, I've definitely seen bladders that have been, kind of paper thin, and also like bladders that may be really like overly thickened. I feel like you can get either or. For the really thickened bladders, from a closure, you overall are going to have a lower risk of seeing tearing or anything like that. So I think, but you want to make sure you get good apposition and that you don't have too much gapping in your closure. So thinking about doing a 2-layer closure Maybe doing like a simple continuous for the mucosal and then doing a simple interrupted on top of it is probably what I would do. For when the bladder is like paper thin and is really difficult to handle, like, the most important thing is just gentle tissue handling techniques. Trying not to touch the bladder with your bare hands or with instruments, maybe using stay sutures more than anything, of a relatively fine suture material. When it comes to your closure, making sure you take wide bites. You don't want to, leave just like a millimeter on both sides, like maybe a half millimeter on to really get a good size to your bite, so that the tissue has, or at least the suture has, a little bit more tissue to grab. And after that, like if the bladder is fragile, the best thing that can be done for that bladder is to minimize the amount of pressure that's going to be on that incision. So leaving an indwelling urinary catheter. There's a variety of situations where we may have to leave an indwelling urinary catheter for, but the urinary tract in general has a really robust ability to heal. Kind of along the same lines, like there have been some cases where we've known that there's a uroabdomen but can't find the source. Like if you can get a Foley catheter into that dog's bladder and just leave it in place for a week, you have a really good chance of that will fix the problem on its own. So just leaving a Foley catheter in. What some owners might have trouble dealing with is that it's not that you leave a catheter in for a day. Like if you really want to be sure, especially if you're concerned about compromise, like it takes the urinary tract about a week to heal. So the safest thing that you could do is keep that bladder as empty as possible for about a week.
That's a wonderful tip. Thank you so much. Well, that was all of our clinical questions. You have been on the podcast before, so you know about rapid fire. Did we scare you off last time, or do you want to play again?
No, we'll play again. I was funny. I mean, I was really tired the last time, so I can't really remember what the questions were.
Well, I looked them up to make sure I didn't ask you the same questions. So they are going to get new questions.
All right.
All right, here we go. Would you rather have 24 hours of like intense emergency surgeries back to back, or have an entire week of nothing but post-op TPLO rechecks with absolutely no complications?
I would go 24 hours of emergency surgery.
You're an adrenaline junkie. Go.
Yeah.
Would you rather redo your residency or redo high school?
Oh, 100% redo my residency. I had a great residency with a great group of people. I would 100% do that again.
Excellent. Would you rather do nothing but soft tissue surgery or nothing but orthopedic surgery for the rest of your whole career?
Definitively nothing but orthopedic surgery for the rest of my career.
All right. Okay. Did you play with Tinker Toys when you were little?
The Tinker Toys are the erector sets. I used to love erector sets.
Mm-hmm. Mm-hmm. Would you rather have a TikTok famous dog for a patient or a famous Hollywood actor for a client?
The problem is we've kind of had both. I would probably go with a TikTok. No, I'm going to go with a Hollywood famous actor.
Hollywood famous actor. Okay. Yeah. All right. And final question. If they were both still alive, would you rather perform surgery on a stegosaurus or a woolly mammoth?
Woolly mammoth.
A woolly mammoth? Why?
Because at least it's a mammal.
Okay.
And I don't know what to do with exotic.
And you're not a big reptile person?
No.
All right. Well, that was all of them. I had fun playing. I hope you had fun playing with us. And I hope you enjoyed being on the show again. It's always such a pleasure to have you. So thank you to our audience. Thank you again for joining us. And I hope you found this discussion as informative as I did.
Yep. Thanks for having me back. It's always a pleasure.
Thank you for joining us for today's episode of Clinicians Brief the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the podcast is a Vetmedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.